education for this series. In order to receive a CME or CEU, participants must complete the online evaluation at the end of the webinar. Your comments are very important to the planning committee and will be used to plan future programs. Health professionals, you can now check on your CME credits online. Go to www.queens.org and type CME in the search tool. Click on My CME Transcript, then sign in to generate your transcript. About ECHO. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. So it will take all of you to create this community of learning. In the spirit of aloha, we encourage you to turn on your cameras to help us build a community of learning. Feel free to eat during the ECHO session. Good nutrition is key to a healthy lifestyle. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open up the time for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to the topic of today's lecture. We only ask that you keep it a HIPAA-compliant case for discussion. That means, please, do not share the patient's name, birthday, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I'm Juanette Gaylord of Alliance of Residential Care Administrators, ARCA. We have Maribel Tan, President of Foster Family Homes Association, Elsa Talavera, President and CEO of All Island Case Management Corporation, May Magnayan, nurse with Lokahi Case Management, Madeline Kim, social worker, student, and CHW at Aloha Care, Leila Ventar, Health Coordination Manager from United Healthcare, Kauai County, and Dr. Ritabel Fernandez from University of Hawaii. We are in the second month of our series on mobility. If you're interested in viewing any of those lectures and handouts, you can find them on our website. Unfortunately, we cannot offer certificates of attendance for videos you have viewed. You must participate in our education live. The title of today's webinar is Don't Fall for It, diving into fall risk and prevention in the older population. Joining us today is Dr. Cody Lim. Cody is a practicing physical therapist who currently works in the outpatient orthopedic setting with previous experience in the outpatient pediatric and inpatient neural settings. He was born and raised in Waipahu, graduated from Waipahu High School, and obtained his Bachelor of Science in Kinesiology from UH Manoa before obtaining his Doctor of Physical Therapy degree in 2021 from Pacific University. We are grateful for his time and expertise and for his important work he does to support our community. Welcome, Cody. We're delighted to have you with us today. Aloha.
All right. Hi, everyone. How are you guys doing? I know everyone's probably on mute, and I guess this is my cue to go. And so what we're going to do is I'm going to share my screen really quick and make sure that everything's going really well. All right, we're going to share this. And let me see. You guys see that? Give me a thumbs up if you guys see that. Yeah. Thank you so much for that. And sadly, I cannot see everyone because of the format. So with that, it's okay. We're going to get through this. And let me see. Hold on. Let's do this. There we go. Okay. All right, guys. So, yeah, my name is Cody Lim. I'm a physical therapist, graduated from Pacific University, and I'm here. But the thing that we're going to talk about is mobility. And so, first off, I know a lot of us are caregivers and all that jazz, where they're primary, secondary, and all that. But the main thing for this is if I ever go too fast, if you guys don't understand what I'm saying, feel free to stop me. you just like chime in, say, hey, I don't understand this. This is going too fast, and that's okay. The main thing is not for me to just say all of this. The main thing is that you guys understand and you guys get to learn. I understand a lot of us here are caregivers, and falls are one of the biggest things that we deal with, and that's kind of what we're here to learn about and try to prevent as much as we can. Yeah. So let's get started. So what we have here first is our learning objectives, okay? So in terms of learning objectives, there's a lot on the screen. I'm just gonna read through them, but there's six main ones I want to go over. So the first thing is to define what a fall is. So we want to understand what qualifies as a fall and how it is clinically defined, okay? So that's the first thing. The second thing is we want to understand the fall statistics. So falls don't just happen randomly. There's statistics behind it in the US, and we want to be able to understand it. So I want to understand the scope and the prevalence of falls in the older adult community. And by older adult, I'm talking about like 65 years and older. But this can be something that can range from just general. Like some people like to consider 50 as an older adult, but 50 is the new 40 and 40 is the new 30. So everyone's getting younger anyway. Next, we want to identify the contributing factors. So we want to distinguish between intrinsic, so person-related, and extrinsic environmental related risk factors for a fall. Fourth, we want to understand the preventative measures. So we want to apply strategies to address and reduce fall risk for both the intrinsic, the person-related, and the extrinsic environment-related, okay? Number five, we want to recognize and use DME. So if you guys don't know what DME is, they are durable medical equipment. So those are really important to help reduce falls, and we'll talk about that later on. And we want to understand the correct usage. And the last thing we want to go over is we want to know your role and responsibility. So as a primary caregiver, secondary caregiver, in general, you have a really big responsibility of watching over whoever you're watching over, whether it be your parents, a relative, or someone in the neighborhood. That's a big deal with responsibility. So, what is a fall? This is the first thing we're going to look at. So, a fall is an unintentional and uncontrolled change in position resulting in a person coming to a rest on the ground, floor, or lower level with or without losing consciousness. So, falls, man. As a physical therapist, we deal a lot with falls. A lot of people over 65 years old. We'll look at the statistics later on, but some things with like uneven ground and all that, when you fall, the main thing about this is being unintentional, right? Most times you don't plan on falling, whether it be up, downstairs, going up and down a hill. We don't plan on falling. No one likes falling. It's not fun. And so anytime you go from standing and then you end up on the ground, or you end up on top of a table, or you end up onto a couch, even though you're not on the ground, right? Even if you fall on a couch, that's considered a fall. And those are really important that you take note of what a fall is considered, right? You also have things that people bring up of like a slip and fall or a trip and fall. A slip and a trip, those are all things that if you slip, that's kind of like your feet moving away from underneath of you, right? So it's kind of like if you put something up on the up standing, if you knock out the bottom, that's when you slip forward, like stepping on a puddle. A trip is kind of like when someone catches their foot, and both of those things often happen in our older population. So we want to minimize that as much as we can. All right, so here's some statistics on fall data, okay? So injuries, so it is the number one cause for injury-related deaths and disability for adults over 65 years and older. And that's a lot, right? When people are younger, you have, random accidents, falling, sport-related, vehicle-related, illness and all that. But when you start to get older, fall's a really big thing that plays into both injury, death, and disability, okay? And so annually, there are 14 million older adults, so 65 years and older, in the US who experience a fall every single year. So at least one fall, which means 1 in 4 adults. So I know we have a lot of participants in this room. 1 in 4 of you guys, please don't, but 1 in 4 of you guys will experience at least one fall this year. So please be safe. But the statistics are there that it happens. As a physical therapist, we see a lot of people come in through our doors who a lot of us are rather healthy at an older age, but all of a sudden it takes one fall, whether it be intrinsic or extrinsic, that can cause us to kind of decline in health and cause us to have an injury, okay? The next thing we're going to look at is the medical treatment. So 30% of those who fall paramedical treatment or an ER visit after the incident. Um, Recently, so one of my side gigs, apart from being a physical therapist, I actually teach Zumba. I don't know if you guys know what Zumba is, but I teach Zumba for fun and I teach normal Zumba and I teach Zumba Gold. So that's kind of like dance fitness and all that fun stuff, cha-cha, all that. And I recently had someone fall, well, two different people fall in my class within the past month. And it's pretty sad, pretty scary because when everyone's getting ready for Zumba, people's finding their places, everyone's dancing, and then all of a sudden someone ends up on the ground, and you're like, oh my goodness, like what is happening? And really, the moment someone falls, we'll talk about it later on, but it's important to one check on them, but also get health services pronto, right? Even though it might be like, oh, I just kind of hurt my ankle, it's important to get checked out as soon as you can because there might be more. And unfortunately, the two people that fell in my class, they did hit their head, and we did call the ambulance. And luckily, we did because there was more injury than just hitting the head. So we'll see about that later on. And then mortality rate. So 70 people per 1,000. There is a fall-related death rate among adults age 65 and older. So it's quite a bit. Whenever someone falls, even if it's a small fall or a big fall, there's always injury that comes from it. A lot of times when people come in, they're like, I just fell from the towel, like reaching for the towel rack in the bathroom. When the body experiences a fall, there's almost like this shock factor, right? Emotionally, you're kind of scared. You're like, oh my goodness, I fell. But physically, there's this weakness that kind of occurs with your body. All of a sudden, after a fall, your muscles feel sore. All of a sudden, you feel a little bit weak. All of a sudden, you feel a little scared. There's apprehension, and there's fear about things. And that's one of the things that makes falls more prevalent is when you have fear or apprehension or you're unsure of yourself. That plays a big role into injury. And so, impact, 1 in 10 falls result in a serious injury that restricts daily activity and independence. That's a big one. So, one of my patients, one of my Zumba Golden people, when they fell, one, they hit their head and they were fine, no concussion, which is good, but they actually fractured one of their ribs and they also hurt their wrist. So, there's a lot more that happens to a fall than you think. Even with my patients, um, something small as like tripping on the stairs coming up, all of a sudden they have a big wound, a big bruise all on their leg. And those are things that are important to pay attention to and not to allow them to fly under the radar. Sometimes we get scared, right? When something happens to our patient, the person we're in charge of, right? There's this fear that, oh shoot, like they fell on my accord, I'm in trouble. That shouldn't be your fear. Your fear, it shouldn't be fear. It's more of a responsibility like, oh, shoot, they fell. This is what I need to do. I need to let people know that this happened so that they can get their needs met in terms of getting checked out. Um, that's really, really important. Don't, that actually goes to our next part. So falls are actually very much underreported. Many falls are never reported to the healthcare providers. The true scale is likely far greater. So that's the hard part. A lot of people, whether they're the patient, the person you're caring for, or as the caregiver, if someone goes down, there's a high chance where sometimes people are scared to report it. And in the data, like we have like 14 million, 1 in 4 people will fall a year, right? There's a likelihood that the falls are actually a lot higher than it is. And that's all because people are like, oh shoot, I don't want to say anything. I'm too scared or I'm too nervous to let them know. But let people know you need help. That's really important. Okay. So now we're going to go on to the next thing. Okay. So fall risks. So understanding what puts older adults at risk. All right. So the first thing we have is age. So we can't deny it. Age is going to happen. Age is approaching us. Age is going to happen. So the risk of falling increases significantly with age. Older adults face compounding physical changes that reduce stability. So there's a lot of things, and I'm going to talk about them soon. As we get older, it's going to happen where our vision's going to go out, our muscles get weaker, our balance gets worse, and all these other health concerns come on. So, in terms of vision, Our vision worsens. A lot of us probably here use glasses or contacts, and that reduces our spatial awareness and depth perception. So even at nighttime, sometimes some of us need glasses when we drive and all that. And so if we need glasses for our driving, how much more do we need glasses for walking to keep us off or keep us safe, right? And so, in terms of weakness, musculoskeletal weakness from reduced muscle mass and poor nutrition diminishes strength and postural control, right? As we get older, sadly, we're not as like fit as we are when we're younger, right? So I don't know if we have any bodybuilders here, but as we get older, our muscles will start to shrink, right? Our protein intake, our nutrition starts to reduce, and that's one of the big things, right? As we get older, our diet starts to change. We can't eat a steak like before. And all that protein that we take helps strengthen our muscles. And as we reduce that intake, right, then our muscles start to shrink. And that can lead to issues where it gets hard for you getting out of bed, getting up from a chair, right? Next, we have balance. So balance relies on three integrated systems. So we have sight, proprioception, and the vestibular system. So sight is easy, right? Sight helps with balance. If your sight is all giving you like your double vision, then your balance is going to be a lot harder, right? So you have your sight. Proprioception, if you guys don't know what proprioception is, it's just a fancy word of knowing where your body is in space, basically, right? Um, and so some people, when there's issues with proprioception, an example is like when your leg goes numb and you can't feel it. If that numbness occurs, then you can't really tell where your foot is in space, and it's hard to balance on it. And then you end up falling, right? It's kind of like if you're on the toilet for a long time and then you start to get that numb feeling from being on your phone for too long, that can lead to falls. And last is the vestibular system. So a lot of people talk about, shoot, what's it called? Yeah, you have little rocks in your ears, the vertigo, right? And so when people talk about vertigo, it talks about the vestibular system in our ears. So every time we move our head, there's little rocks in our ears that tell us where we're going, how it's turning. And sometimes those little rocks get dislodged, and so when we turn our head, all of a sudden we can't tell what's happening because it feels like everything is moving around us. And so comorbidities are the next thing. So as we get older, many different health issues come up. Hypertension, hypotension, diabetes, Parkinson's, stroke, poor bone health, all of these significantly increase your risk of falls. Anytime your blood pressure gets affected, that can affect kind of your consciousness, right? Some of us, when we have patients or people who are laying in bed for a long time, right? Maybe if you're sick and you're in bed for a long time, and all of a sudden you stand up and then you feel like you're about to pass out, that's called orthostatic hypotension. So big fancy word, but basically your blood pressure all of a sudden tanks, it drops. And because all of a sudden your brain is not getting enough oxygen, there's that feeling of passing out where you fall back. Hopefully, you fall back on the bed, or you fall to the ground or something because you're not getting enough oxygen to the brain, right? That happens with diabetes. We have diabetic neuropathies. That's where you can't really feel your feet as much. And that can occur in your feet, your hands, that can all cause falls. Parkinson's is another one where it's hard for you to start going up from a chair, walking through a doorway. Parkinson's can affect that. Stroke, weakness, and all that from a stroke can increase your risk for falls. And one of the big things that happens when you fall is there's a risk that you can have a fracture in your hip, in your bones, and everywhere else. So your bone health is really important. That also goes back to having good nutrition. And the last thing that I'm going to talk about is the improper DME use. So one of the biggest things that happens sometimes when we have people come in to physical therapy is people come in with crutches, canes, to help get them walking, right? To help them get around Costco or wherever. But the issue is sometimes not everyone knows how to use their cane, right? So let's say you have an injury on your right leg. A lot of people usually put the cane or the crutch on the same side. It actually is supposed to go on the opposite side. And that's to help shift your weight onto your quote unquote good leg, right? So those are all important things to know. We'll talk about that later. All right, so let's talk about extrinsic factors. So these are factors from the environment that can affect um, affect you and increase the risk of fall. So right here we have this image of someone's house. I hope this is not how your house looks like. Please, I hope your house doesn't look like this. But we'll look at the image more after I talk about these. So the first thing is like rugs. So anything like a loose or curled rug or major tripping hazards. So if you have something in the bathroom, in the kitchen, down the hallway, those are all things that can increase your risk for falling. Doorways. It's very common that some doorways have a step over, especially in Hawaii. Some of our older houses, they have like door frames and certain like step overs to get through. That is another big risk. Stairs and ramps, uneven or poorly lit stairs or high risk zones. So not even just the lighting of the stairs, but also the step height, right? There's a normal height for stairs and ramps that are safer for you to go up and down with. And sometimes some houses they'll just build them any kind. The steps will be all these weird heights, and it can actually make it harder for you to walk up and down stairs. Uneven ground, cracked sidewalks, or uneven flooring, or another risk for instability, and clutter. That's another big thing. A lot of us in Hawaii, sometimes we're hoarders. Sometimes we have all these boxes and magazines and all these random things hanging around our house, and that makes an increased risk for falling. Okay. So back at our picture, if you guys look at it, there are so many things. So at the hallway, we need to tell Grandpa to move his shoes. We have the rugs, we have a power cord, there's a lot of things around there on the floor. So those are all risk for falls. And it looks also kind of dark. It looks like someone probably took a picture of this with their flashlight on their phone on. So you also want a well-lit hallway. That's an important thing. In the bedroom, there's just a lot going on. We have books on the ground. You have clothes all over the place. There's a small table. You're gonna trip on all of that. In the bathroom is really a place where you don't want to fall. Especially getting in and out of the tub, right? Getting in and out of the tub, if you have a step over, it's always a challenge because you're gonna have to keep that balance on one leg, right? If the floor is wet, if the towel slips, it's not gonna be good for you. You're gonna fall. And lastly, in the yard, um, it's just all over the place. You have a hose, you have a rake on the ground, uneven ground. Those are all important things to look at. And so these are all external environmental factors that can play into fall risk. Okay. Next thing is we're going to look at prevention. So with prevention, we're going to look at things to reduce fall risk with proactive measures. Okay. All right. So the first thing, so in age, we can't deny it. We're gonna get older, and so the best thing we can do is kind of go with the flow. We roll with the punches, right? We can't change the natural aging process, but we can adapt our approaches. So when things start to change as we get older, go to the doctors, get yourself checked out, and do the things that you need to adapt to the changes of your body, right? For vision, ensure proper eyewear with up-to-date prescriptions, use lighting aids and nightlights to improve spatial awareness. So that's kind of both internal and external, right? Internally, you want to get the right glasses to see what you're doing, but also you want to get enough lighting. Now, you don't need to turn all the lights on at night, but enough so that you can safely make it down the hallway. Strength training, you want to go beyond walking. Strength training, at least 3 times per week, builds muscle mass and reduces fall risk significantly. So, one of the things that I see a lot is with my patients is a lot of people will be like, I walk like 30 minutes to an hour every day. And I'm like, that's amazing. Like walking 30 minutes to an hour, that your lungs are pumping, your heart's pumping, everything's good, your cardiovascular system is great. But just because you walk, it does not mean your muscles are getting stronger. And when I mentioned that to them, they're like, what do you mean? I'm supposed to be super strong. And I was like, as much as that helps, right? Walking, I don't want you to stop walking. That's the main thing. Keep moving, but you have to be able to support your muscle and bone health, right? Every time you push weights, every time you lift something, your muscles get stronger. They start to get bigger, right? And at the same time, your bone health increases. Bone is very interesting because people think, oh, whatever bone grows, that's what you keep, right? But as you get older, your bone density, right? Your bone density starts to decrease, and that can lead to fractures, right? And so, but what most people don't understand is by strengthening and lifting weights, it actually increases the strength of your bones. So that's really important. Okay. So balance training, you also have to incorporate targeted balance training. So Tai Chi, single leg stance, stability boards. into your fitness routine. So a lot of times when I tell my older patients to start working out, right? And they're getting at the end of physical therapy and I'm about to discharge them. I'm like, okay, here's your exercise. And a lot of my patients are like, so I have to do this every single day? I want people to think of exercises not as a punishment. Exercises are not as a punishment. It's more something to just keep your fitness going, right? That should be something fun, right? You want to go out to the park, take a walk, and then maybe do some squats. Those are all things that you can do to get the blood going, and just release those natural endorphins, right? Positivity, increase your mood. So those are things that you can do, and it's also great, right? In balance training, there's Tai Chi. I teach Zumba Gold, and there's varying different things for that, right? For me, as a Zumba instructor, I have to make sure that people are safe where they're dancing, but also I take in account, can they see what I'm doing, right? Can they hear what I'm doing? So those are all the things. And then comorbidity management. So regular checkups plus brown bag medication reviews to identify fall risk drugs and interactions. So with things like blood pressure management, it's important to get checked up by your doctor to make sure you're taking the right medication. And if you guys don't know what a brown bag review, that's basically when you take all your medication to our either pharmacist or your doctor, and then you go down every single medication to make sure things are right for you, and make sure you understand if things are interacting, right? As when we're younger, sometimes if we're in pain, you just pop a Tylenol, right? Pop an Advil, everything's all good. As we get older, all of a sudden you have medication for diabetes, you have medication for increased cholesterol, you have medication for blood pressure. And then when you start having multiple forms of medication, there's this thing called polypharmacy. And polypharmacy is an issue because when you're taking all these different drugs, it helps one thing, but it causes a shift in another thing, right? All of a sudden, you take medication that stops you, that like lets you release water, right? That lets you pee, but then also you're more thirsty, so you're taking more water. Then your weight changes. There's a whole list of things that happens, and it's really important that you do brown bag reviews so you understand what medication you're taking, what it's for, and if there's any interactions. Okay. Okay, so extrinsic prevention strategies. So here's our little kind of diagram here to reduce risks for falling at home. So I'm gonna look at the figure first. So in the bedroom, you want to keep a light on in the bedroom, or just keep a light in the bedroom that you can control with a light switch that's either near the bed or a place that's easy accessible. Places for you to sit, to stand, to put on clothes. As we get older, it's harder for you to balance on one leg to put pants on. So you want to be able to safely put your clothes on. For stairs, handrails are really important. Sometimes some houses only have rails on one side, and as you get older, you realize it's important to have rails on both sides. And sometimes as you get older, this is actually very common. I've had many folks, as they're aging, they actually end up moving to a house that's just one floor. It makes it a lot more safer. And especially if you're a caregiver, especially having like an aging adult or aging parent, right? It gets tough having someone go up and downstairs, and you're not always there to take them up and downstairs. So it's good to have just a single floor so it's easier and safer for basically everyone. No falling downstairs. Things to also have is like anti-slip strips on the stairs. Wooden stairs are actually pretty crazy. Easy to slip on, especially if you are wearing socks. So you want grippy socks if you do wear socks. Or sometimes footwear inside the house that prevents you from slipping. Again, night lights in the hallways and stairs. And the bathroom, so it varies in the bathroom. If someone can safely get in and out of a tub, that's good. Just make sure there's nothing that they could slip on, or there's no puddles around. If you do have floor mats in the bathroom, make sure that they're non-skid. That's really important. And then if they are someone who needs some help in the shower, make sure they have shower chairs or grab bars to help them get in and out. Yeah. Another thing that's important is using a riser seat on the toilet. I have a patient who is a lot older, in their later 80s, and one of the issues that we have is getting up and down from the toilet seat. It's a lot harder than you think. When most toilets, they're actually quite low, And so when you go from, if you're using a walker to sitting on a toilet, you want to make sure you have the right equipment around you to safely get down, get up. And then you throw in the fact that you have to pull up and down your pants. That's a whole different story. Kitchen, want to make sure that everything is accessible, things on the shelf. Make sure that you're not reaching over too far, reaching high up, going on your tippy toes. Those are all risk for falls. Making sure you have the right chairs and all that, especially with the dining room. Usually, dining rooms have like smooth flooring. And so, if you have a chair there, if your chair is really light, there's a chance that your chair will slide out from under you. So, it's important that your chairs have stoppers underneath that, or your chair's on the heavier side so you don't have to risk the chair sliding out. And then in the living room, same thing. Your cords, you want them hidden out of the way. We don't want any tripping hazards. You want a chair that's nice and supportive. If your chair is really low, this is a big thing. I have a lot of patients who are living in like old Asian households. If you have low couches to the ground, it makes it incredibly hard for you to get up from a chair that's really low. So as you get older, right, it's easy to have a one-story house and it's easier to have chairs that aren't that low. It makes it much more easier to get down into sitting. All right, so again, proper lighting. We want to ensure all areas of the house are well lit. Hallways, stairs, bathrooms. You want proper flooring. Secure the rugs or remove them if they can't be secured. Use non-slip bathroom, kitchen mats. Keep away all the clutter and make sure everything is ADA accessible. So modify the house where you need to. Ramps, doorways, and everything. Depending on the patient you're taking care of or your family member, you might have to change your house to modify for certain things, right? If you need a ramp for a wheelchair, that's something to take in consideration. Doorways, right? You want to make sure you can fit the wheelchair through doorways. But one of the other big things about this is if you decide to make your house ADA accessible, it's important that you follow guidelines and you look around for contractors who can help you because you can't just throw any random ramp or any form of stairs or any rails on the wall because you want to make sure that they're safely secured. You want to make sure that the grade, which is the slant of the ramp, you want to make sure it's not too crazy, right? It's going to be really hard to push grandpa up a super, super steep ramp. So those are things you want to be mindful of. All right, and next we're going to talk about DME. So these are tools for fall prevention. So examples of DME are walkers, canes, wheelchairs, and many other equipment. Okay. So what is a DME? So DME stands for durable medical equipment. So that consists a lot of the things that you see in this diagram over here. So there are things like things for eating and grooming, toileting, bed transfers, mobility, dressing, walking. So a lot of these, you'll learn about them through physical therapists as well as occupational therapists. So there's a big team, right? We're the rehab team, and we work together to make sure that everything is safe and accessible for you at home. So DME, what are they? They are durable, so they can withstand repeated uses over times, right? When you have a cane or a walker, you're not using it for like one day and you're like, oh, shoot, I have to get a new one. DME are meant to last for a long time and they're supposed to be able to take a beating, right? I don't want you like swinging your walker around or throwing your cane all over the place, but they should be able to handle like getting put into the car and being placed in different areas, right? There's usually a medical purpose for using DME. They're usually prescribed for things such as weakness of the legs, or like if someone has had a stroke, right? Then you'd want a cane to help support that side. They're usually medically necessary, so typically only useful to someone who is sick or injured, right? If you don't, well, let's put it this way: if you're not sick, then you shouldn't need a DME. You don't need one just prescribed, right? And then home use, they should be intended and approved for use in the patient's home. And then longevity, they're expected to last at least 3 years. So things like wheelchairs, walkers, canes, and all that. So yeah, in this diagram, we have a lot of things. So as a physical therapist, there are things in the home setting that are important. So canes, crutches, walkers, those are all used for your the people you're caring for. Wheelchairs are also important. Things that I haven't seen as often in the home setting because most people can just make through with assisting with transfers. But slide boards are one thing, or if someone has a lot of difficulty as a caregiver moving a patient, then there's also like the Hoyer lift, which is like basically like a cradle to help move someone in and out of bed. All right. So again, examples, canes, crutches, walkers, wheelchairs, commode chairs. That's another DME that's important. Hospital beds, Hoyer lifts, and transfer boards. And what we actually, many people overlook is DMEs. There's also non-mobility DMEs. So continued positive airway pressure machines. So like CPAP machines to help you breathe at night, glucose monitors or DMEs, infusion pumps, lymphedema devices, oxygen equipment, respiratory assisted devices. Those are also considered DMEs. All right, so back to the cane. Okay, so the proper use of the cane, we're just gonna look at these 5 steps to use a cane, right? So the correct hand, hold the cane on the stronger unaffected side of the body. So that's usually the opposite side. So let's say my right foot is the side that is injured. I am not gonna hold, or I shouldn't hold the cane on my right leg, on my right arm. I mean, the reason why is a lot of people think, right, if I step forward with my right, I can put all my weight in that right hand to help support me. For the most part, if you're strong enough in your upper body, you could technically safely do that. But right, if you think about the way you're moving, you don't move your right hand with your right leg when you walk forward at the same time, right? You actually swing forward with your opposite arm. So when I walk forward with my right leg, my left arm goes forward, you interchange, kind of like when you go up a stairs, your body moves oppositely. And that's a way to help safely get you up and down. There's kind of like biomechanics, the way your body moves. And it also allows you to push your weight more on that stronger side when you step forward, right? So if my right foot goes forward, my left hand with a cane goes forward. Another thing that's important is you want to have a correct height for the cane. So canes, and this goes for canes and crutches and even walkers. So the top of the cane should align with the wrist crease. So right over here, when the arm hangs naturally at your side. So I can't see myself. Hopefully you guys can see this. So if I have my wrist here, the handle of the cane or walker should actually be in line with here. So when I grab it, I have this slight bend in my arm. Okay. If someone is walking with a cane or a crutch or a walker and their shoulder is up near their ear, or it looks like they're reaching down for it, that's not positioned right. And that can actually lead to a lot more risk for falls. It's not supporting them the way they need to. And then, so step pattern, so moving the cane and weaker leg forward together, then step through with the stronger leg. So even with going up and down stairs, which is our next point, you want to lead with the stronger leg. So if you have someone you're taking care of and they have a weaker leg, when you go upstairs, they always say up with the good, down with the bad. And that's because when you go upstairs, your stronger leg is going to be the one that's going to help pull you up to the next step, right? So if you try to step up and you have your sore leg and you try to step up, you have arthritis in the knee, arthritis in the ankle, it's not going to work because you don't have enough strength. There's going to be pain, your muscles are going to turn off. So you switch, you use your stronger leg and you bring your leg, I don't want to say it's a bad leg. You bring your sore leg up to meet that leg. So you're actually going step by step, right? And then going down with the bad. So the other thing is when you're coming downstairs, it's very common, or coming down from a step, a curb, it's very common that people want to put the good leg down to try to take their weight. But if you think about it, when you're lowering yourself down from a step, you're actually slowly bringing your whole weight down forward to the next foot. So if you're using your weaker leg on a step and you're letting yourself come down, if that weaker leg gives out, you're gonna fall, right? But if you keep your strong leg on that back step and you slowly let yourself down, you can bring your crutch, your cane, whatever walker or assistive device you have, down to help support you, and then you can meet yourself with that good leg. Yeah. All right. So I think this is our last slide. So the last thing I want to leave with you guys before we start talking about patients and the people we're caring for, right? Fall risk and recognition and prevention starts with you. So as a caregiver, you have a really important role of recognizing things in the house to make sure it's safe for the family, whoever you're taking care of, parents, family friend, grandpa, grandma, auntie. You want to make sure that the environment is safe. And at the same time, you want to make sure that whatever needs that they need to have met, intrinsically are met, right? There's a lot of times where, as a caregiver, and we'll talk about this to get deep, but being a caregiver is not easy by any means, right? There's a physical and mental load of being a caregiver, and there are times where you're stressed out and all that jazz, and right, not, most people don't really sign up to be a caregiver, but when you're in that position, there's that responsibility that, hey, like I'm in charge of someone, I'm here to help them. And so it's important to be able to take people to their medical appointments, to make sure that they have the right glasses, medication needs. Those are all important things to take in consideration. Yeah. And what I like to say is, if it matters to you, you'll find time and do it. So that's a big thing. That's something that I live by. If taking care of someone, grandpa, auntie, matters to you, you will find time to do it. Right. Taking care of your patients and all that, it's sad because there's a lot of people who end up in the caregiver role and they don't always like it or whatever. And it shows in the care that someone takes, and also their safety, right? I've had a friend who works home health physical therapy where she visits homes, and it's really crazy how much someone's home looks depending on whether or not they care for the person. So that's a big thing, right? So recognize, we want to identify intrinsic and extrinsic fall risks or factors early before an incident occurs. We want to prevent. So we want to apply strategies to reduce risk proactively for both the person and their environment. And lastly, we want to act. Every healthcare provider and caregiver has a role in fall prevention, so your action matters every day. Okay, so your awareness and action can save lives. And so thank you. So that was my presentation. Don't fall for it. Fall risk and prevention in the older population. So yeah, if you guys have any questions or concerns, please reach out to me. I'm still going to be here for our talk. But yeah, I guess we're going to open the floor, or Juanette, if you want to take charge.
Oh no, if anybody has any questions, please go ahead. You can either unmute yourself and go ahead and ask the question, or you can put it in the chat box.
Hi, Cody.
Hi.
What an excellent talk. I really appreciate it. This is Jackie speaking.
Hi, Jackie.
I unfortunately I had to pick up a call, so I missed the important part about going up and down, leading with which leg and things like that. So would you mind summarizing?
Yeah, no problem. So with stairs, one of the common sayings that most people will say is up with the good, down with the bad. Or people will use like the metaphor of like heaven and hell. But you want to use your stronger leg to go up a step. And that's because when you step up on something, right, if there's a high curb or anything, your stronger leg has the job of lifting basically your body weight, right? So
Okay.
like I'm like 160 pounds. My right leg, if I step up with my right leg, it has to be able to lift and move 160 pounds. So if you go upstairs, you want to use your strong leg. And when you come downstairs, most people want to try lead with their strong leg, but it's important to actually come down with your weaker one. And the reason why about that is when you come down from any step, there is this slow descent of your body as you lower down to the next step. Okay. So if I'm coming down, if I use my weaker leg on that step and I come down with my strong leg, what happens is all 160, 170 pounds of myself will go right onto that leg. And if it's weak, it's going to give out. So you want to keep that stronger leg on the step, slowly lower yourself down so that you can like bear weight on that weaker leg, holding onto the rail, and then that other leg can meet it. So up with the good, down with the bad.
Thank you.
Yeah, no problem.
Okay, so we have a few questions in the chat box. It says could you share more about fear of falling? Asked by
Yeah.
Madeline Kim.
Hi, Madeline. Yeah, fear is a big thing. Fear, hesitancy, apprehension, all has different um words to describe it. But basically, whenever there's fear and uncertainty, what happens is there's almost this like, ooh, like I don't want to go. And that split second of like, let me pull back, let me move, let me do this, that can lead to a lot of like shift and movement and loss of balance. For example, like if you want to step down to a different step, you're walking downstairs. If there's that moment where you're scared to walk downstairs, there's a high chance that you might actually lose your balance, where it like your strength falters. Um, Fear actually plays a big role in things like that, right? If you think about like dancers on stage, right? Let's say a ballerina. Ballerina has a crazy performance, right? If for a split second she does a turn and all of a sudden she gets scared, you're gonna see her wobble, right? She might fall. Same thing with gymnastics. You see like Simone Biles, right? They're on the balance beam. A lot of that is confidence, right? If you lose your confidence, even with just walking down the street, right? You lose your confidence walking down the street, there's a high chance you might like end up tripping. So those are things that play into fall risk. Let's see. Yeah, so that's fear of falling. That's a big thing. Don't be scared, but be confident in your walking ability.
So Priscilla is saying, thank you, Cody. More refreshing for our daily life as caregivers. God bless us all in taking good care of elders. Yeah, Mason is asking a question. Can you suggest physical fitness for clients that has unsteady balance?
Oh, yeah. Well, so in terms of clients, so it's very it all depends. That's the first part. One of the biggest words that physical therapists say, it all depends. Right? Not everyone has the same movement disabilities or balances or strengths and weaknesses. So in terms of physical fitness, let's say someone's recovering from an injury, like physical therapy will give a good framework of exercise that people can do. One of the other things that I've seen a lot of older folks do is like you'll go to like the gym, they'll do like silver and fit, silver sneakers, all those fitness classes, which is nice to do because a lot of the coaches that are there, their job is to make sure that you're doing things safely, um, and you're able to get your strength and mobility going. And so even if you do that, like let's say you have weakness and all that stuff, um, if you're advocating for a patient or you yourself want to go to like Zumba Gold, that's the easiest way I can say it. If you haven't done anything, right, and you're scared, again, there's that fear, right? If you're scared or apprehensive, do the things, the steps that it takes to make yourself feel more safe and confident, right? So if I had a person at the gym come into my Zumba Gold class and they're like, I have never done Zumba Gold. I don't know what to expect. I'm scared I might fall. I'm gonna tell them you can come into the class, you can sit on a chair, you can do Zumba Gold sitting down. I'm gonna have my microphone. I'll be right here. If you can't see me, feel free to come right in front. So those are different things that you can do to talk to people. You can have personal trainers, that happens. Those are all things that people can do. And so for unsteady balance, like Tai Chi is actually a really big one that a lot of people do to help keep their balance. Weight shifting is really important. As we get older, we don't always know our boundaries of balance, right? If you leave your boundary of balance, that's when you fall. And so Tai Chi is a great way to challenge it and kind of see and feel how far you can move your body. Let me know if that's a good enough answer.
So I guess I have more like a Medicare coverage question. You know, I understand how normally when they get discharged from a facility, a SNF, they have is either or both physical therapy, occupational therapy. Would you know really how many allotted sessions they're able to get within a 12-month period of time?
Ooh, that's a good question. It varies a lot. Off the top of my head, I'm not well versed on the total amount. But what I will say is, depending on what you're coming in for, it will affect how many sessions you get, as well as what your doctor prescribes, right? So physical therapy in general is a direct access tool. So if you have quote unquote the money, you can just go to PT and just pay and then have physical therapy. But no one wants to pay out of pocket. That's a lot of money, right? Depending on the clinic. And so we have insurance. So in order for insurance to cover for physical therapy, you have to get a script, and then there's communication between doctor and insurance and doctor and us. So once insurance goes, yeah, you're free, they'll give things like for low back pain, right? Low back pain is a big thing that affects people's mobility. Usually we'll see people for like 2 times a week for 4 weeks or 2 times a week for 6 weeks, depending on the injury or the severity. And in that time, the idea is you want to continue to strengthen and reduce whatever pain and get people moving. Um, but sometimes what happens is we get to that end of that 4 weeks, 6 weeks, and either we made improvements or maybe things stay the same or maybe there's a decline. Whatever happens, we reevaluate and see what changes happen, and then we go back to doctor. So normally the communication, it's you see doctor, come to us, we go through PT, and then you go back. And then depending on doctor, they can prescribe more, and then we see from there. And so with insurance, it can be insurance finicky with insurance, whether it be like if you're doing like an HMO like Kaiser or something, or you're doing like HMSA, different clinics and different insurances work differently. So it's important to talk to the clinic like administrator and all that jazz. That plays a big role.
Anybody else want to ask a question? I'm reading one from Melita. She says, sometimes the patient has no possibility of improving, bedbound, wheelchair bound, cannot stand on his legs or cannot bear own weight, expanded, total care, yet PT and OT still coming despite no chance of improving.
Yeah, that is something that happens actually quite often. So going back to one of my friends, she graduated from physical therapy school, same time as me, and she was a physical therapy assistant. And so she did home health PT, and it is interesting because, right, when we have someone we're taking care of and they're basically bedridden, they're not able to move, one of the ideas is, okay, do we just leave them there, right? But that's not that's not humane. um, and so what we have is like we'll have physical therapy come in to help get things started, even though someone can't bear weight and they can't move, they have difficulties. There's different ways that we try to see what we can do to continue strengthening someone. That's the main thing, right? We want to keep people moving as much as we can, right? I know that we have, parents or people who are laying in bed, but you don't really know what can be done. But that's where our role as a physical therapist comes in, right? And the other way I can say this is when people come in through our doors for physical therapy, our job here is to make it easier for them, right? So that there's less pain. But our job is also to educate people, right? As much as I love talking to my patients, you make friends with patients, yeah. Talk story, learn about their grandchildren, all that. What I always tell people is I don't want to see you here every day. Your goal is not to work me into your schedule. Your goal is to be able to grab the tools to put them in your toolbox so that you don't come back here, so that you can be able to function safely by yourself in the community without seeing me. So I tell my patients, if I'm going to see you, I want to see you at Pacific Supermarket. I want to see you at the gym. Like that's kind of the thing. So, and yeah, if your person is in the bed, is bed bound or whatever, there's different things that can be done to learn to make it better for them, right? Moving them around, bed mobility, comfort, those are all important.
Anybody else have any questions? You can always go ahead and unmute yourself and ask the question.
Does anyone do Zumba?
Oh, there's a bunch of them out there I know that do Zumba.
Guaranteed.
They do them at parties too.
Yeah, everyone's wild. I know you guys can get crazy. And if you guys don't do Zumba, that's okay. That's fine.
Anyway, John, do you want to go ahead and put up the slides? Thank you. So part of our evaluation today is going to include what is called the TUG test. The TUG test stands for timed up and go. So we're going to answer the questions. Do we want to watch the video, please, John?
Up to you if you want to do it
let's
now.
go ahead and watch the video first,
Okay.
so that I can explain the evaluation form. Thank you.
The timed up and go, or TUG, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the TUG is at increased risk of falling.
Thanks, John. Okay, so we're going to go ahead and discuss the evaluation. The way we're going to do it is the first resident that has been with you the longest is the first one that you want to fill out the evaluation form for. Is the person currently unable to walk or stand without full assistance, bedbound, or non-ambulatory? Yes or no? Remember now, this is for your resident that has been with you the longest. So we'll do resident number 2 will be the resident that has been with you second longest, et cetera, et cetera. So if your answer is yes to the system, you'll skip the following questions and move on to the second resident. If it's no, then you have to answer, does resident feel unsteady when standing or walking? Yes or no? Does the resident worry about falling? Yes or no? Has resident in the past year? Yes or no? And therefore, with the TUG test, you need to do a TUG test on each individual resident. TUG score is greater than or equal to 12 seconds. Yes or no? Okay, we're encouraging you to go ahead and do the TUG score so that everyone, we have a baseline for all of the residents. So first resident, the one with you the longest, second resident, second longest, et cetera, et cetera. We have the care home, the evaluation link in the chat box. Go ahead and complete that. And then we want to send out aloha and mahalo nui to Cody Lim. Doctor, thank you so much for joining us and giving us all of your mana'o today.
Awesome, my pleasure. Thank you, everyone. Was so fun. I know I'm not able to like talk to every single person, but again, if you guys have any questions, let one know, and then I can get back to you guys. But thank you, guys.
Aloha.